Good afternoon, and thank you for joining us for our webinar, Medicaid and the Risk to Providers. My name is Rich Skorupski, and I'll be your moderator. I am the Senior Vice President for the insurance firm Meeker, Sharkey Hurley. I'd like to introduce our presenter, Ivan Punchatz. Ivan is a healthcare attorney with Buchanan, Ingersoll, and Rooney. He has practiced healthcare law for more than 30 years. He formerly served as Deputy Attorney General for New Jersey. Ivan is a Medicaid legal expert. He has a wide range of healthcare clients, from practitioners to institutional providers. Our firm specializes in providing insurance for nonprofit organizations, including Medicaid providers. Medicaid providers are subject to extensive government regulations. If a Medicaid provider is audited, he can face substantial penalties and legal costs. Before we begin, we'd like to make note of the following. We will be taking questions. To ask a question, open the GoToWebinar control panel by clicking the red arrow in the upper right-hand side of your screen. Type your question in the question box and click Send. Your question will be sent directly to us, and we will provide answers at the end of the session if time permits. If we do not get to your question, we will be sure to send an email answer following this session. When I heard Ivan speak at a conference recently, I realized that he could address many of the questions my clients have about Medicaid audits and the risks they face. Ivan will talk about that today and discuss how providers can proactively seek to limit their exposure. So Ivan, before we begin, I was wondering if you could start by giving us a background and some information on Medicaid and the issues providers face.
Thanks, Rich. Just by way of background, I do want to say that I did represent the Medicaid program for 10 years as the Deputy Attorney General, as well as DDD for those providers of disability services, of whom quite a few are on the line today. Behavioral health, I also represented mental health services. Okay, Medicaid is Title 19 of the Social Security Act. It was enacted in 1965, part of the Great Society program with Medicare, but unlike Medicare, which is 100% federally funded and administered, Medicaid is a cooperative federal-state program jointly funded by the state and federal governments. Throughout the discussion today, we'll make reference to the U.S. Department of Health and Human Services, HHS, or the Centers for Medicare and Medicaid Services, which work with a single Medicaid agencies in each state. States must comply with federal Medicaid standards, including requirements as to the contents of their state plans to qualify for what's known as federal financial participation. There are a number of variations in state programs around the country in terms of eligibility, covered services, program administration. And by way of reference, in conjunction with the election last night, there's a strong possibility over the next couple of years that Medicaid will become a block grant program, and some of the stuff we're talking about now may go away. In contrast with Medicare, Medicaid deals with the indigent, disabled, special needs population, while Medicare is an insurance program for the elderly. Medicaid is a benefits program. It's a federal-state collaboration, and it provides much broader post-acute coverage and for populations which are not normally covered by Medicare. On this slide, you see that Medicaid provides a whole host of services. I'm not going to read through them, but we can say that in New Jersey, we pretty much provide everything that Medicaid is allowed to provide, either mandatory or optional under the federal programs. Now, we have different types of Medicaid populations. So we have different eligibility criteria and benefit coverage. As providers, and some of you are going to be new providers, it's important that you know which populations you're dealing with and whether there are mandatory benefits or optional benefits. And just as a matter of reference, a lot of the optional benefits that are going to be covered now were part of the Medicaid expansion program under the Affordable Care Act, which was optional with the states. Again, based on the election results this morning, that could change in the future as well. So Medicaid covers, in addition to the indigent populations, it does cover 9.3 million non-elderly people with disabilities, including 1.5 million. That's a 2013 statement. It's probably a lot more now. It covers all different kinds of things for folks with severe physical, mental health conditions, disabilities such as cerebral palsy, Down syndrome, or autism. As we know, I'm sure all the providers on the call know, these individuals usually cannot obtain coverage in the private market, or the coverage available to them will fall short. So Medicaid provides people with disabilities access to a fuller range of services they need, which is part of the reason why you're all on the call today, because of the move by Medicaid in New Jersey to include U.S. providers. Medicaid is a big program in the country. In 2014, we had almost 70 million people covered. That was more than the 53 million that were covered in Medicare. Expenditures were about 15% of the national total. Combined with Medicare, again, this is 2013, these numbers have gone up. At this stage, they probably provide 45% of the national health expenditures. In New Jersey, we have a single state agency that you have to become familiar with. It is Division of Medical Assistance and Health Services. It is under the Department of Human Services, but Medicaid, DMAHS, is the designated single state agency for administration of the New Jersey Medicaid program. As I said on an earlier slide, the Medicaid program is governed by a state plan, which is a contract or an agreement between the state and federal government. New Jersey state plan can be found online. If you want to jot down, although you can go to the New Jersey Department of Human Services website and locate it there. It is about a 750-page document. It's very confusing. A lot of it is check the box. But that is how, in general, we participate in the state of New Jersey in Medicaid.
So Ivan, there have been many changes to the service model for Medicaid and changes in the service delivery. I was wondering if you could tell us and the providers how to know what's going on.
Okay, as I said on the earlier slide, the state plan is the submission by the state to the federal government, which allows us to claim federal funds in New Jersey. Medicaid is 50% federal funds in New Jersey, 50% state funds. These are subject to review and approval by CMS, which go through the criteria that are proposed, which we will talk about in a little while, are contained in the manuals. You have to meet federal, state, and regulatory standards. Now, we're not going to discuss in depth the process, but states may obtain what are known as Section 1115 waivers. New Jersey has done so. So we have now waivers for services for seniors, the MLTSS waiver. We have a disability waiver. We're going to talk about the supports waiver for the developmentally disabled population. We also have behavioral health services now under waiver programs, which allow the state to do things that would not otherwise be allowed. And when you hear people talking about the states being the laboratories for public health services, they really are talking about the waiver programs, which involve the states now starting programs that would not otherwise be available to people, being paid for by the federal government. These are generally time limited, so unlike the state plan, which would be an unlimited program, all of our state waivers have an end date, whether it's 2018 or 2019, unless they're extended by CMS or unless under Speaker Ryan's program, Medicaid becomes a block grant program. So how do you know, as a new provider, what you have to do or not do? Well, everyone should look at New Jersey Administrative Code, Chapter 10, or Title 10, Chapter 49. That is an administration manual which is applicable to everyone to every provider, whether you're a doctor, whether you're a hospital, regardless of your size, that applies to you. The provisions in there apply to everyone. That's the administration manual. Now, as noted in 1.4, the Medicaid fiscal agent, Molina, and Medicaid itself, the MAHS, maintain manuals for each type of service and type of provider. Okay, so if you are a new provider, you're going to have to utilize the manual to get your instructions. Each manual is written in accordance with federal and state laws, rules and regulations, and with the intent that everything applies uniformly. Each manual consists of 2 chapters, broken into subchapters. The first chapter is referred to as the administration manual, and it outlines the general administrative programs. We've just gone over that. The second chapter of each manual, and by the way, the separate manuals will make reference back to NJAC 1049. The second chapter of each manual then specifies the rules and regulations relevant to the specific provider type. Again, whether you're a doctor, whether you're a hospital, whether you're going to be a developmentally disabled provider, whether you're a behavioral health provider, each manual is going to be specific to you and the types of services you provide. Following the second chapter of the manuals is the fiscal agent billing supplement. Most of the folks on the call today will be billing the fiscal agent, will be billing Molina, at least initially, even though some of you, there is some talk to eventually go to a managed care system. Now, enrollment is again specific and is specifically designated in the regulations. So, for example, for those of you who do behavioral health, there are a number of different mental health rehabilitation providers recognized. Separately, by chapter, by service, for example, residential child care facilities, children's group homes, psychiatric community residents, providers of behavioral assistance services for children, youth and adults, your mobile response agencies, your PACT agency, and providers of intensive in-community mental health rehab, as well as community residences for mentally ill providers. Each one of those I've listed has a separate chapter or a subchapter. Generally, it's NJAC 10:77, but there are also other subchapters that are involved. So it's important for anyone coming in to the program to understand that how you bill, what you have to bill, and what you have to document is separate from provider type to provider type. Most everybody will be using the same billing form, a form 1500, but you're going to be required to have different documentation and different coding for the services you render. So we also, and this was in answer to a question that we got pre this webinar on registration, is whether we're going to talk about the new supports waiver. And we are. And that's good because most of the folks, again, who have signed up are interested in the supports waiver. This is a little bit different. The supports waiver, which is online again at the Department of Human Services website, which is on the slide, does has a little bit different application in that it allows DDD to continue in an administration and consulting role to Medicaid, which is not usual. That's not the way it usually works. In the administration of benefits to adults eligible for DDD services and Medicaid benefits. So as we go through this, we're going to make reference to the supports waiver, which is an amalgamation really of DDD's responsibilities as the oversight agency and Medicaid's responsibilities as the payment agency.
When an organization's audited, we all know that documentation is critical. Can you speak to what steps the provider should take to ensure that their documentation can stand up to an audit?
So let's go over again what I said before. The fiscal agent is Molina, and the New Jersey Medicaid Management Information System, NJMMIS, is the avenue for the provider to go into the Molina system. And you register through that website. And you register with Molina, and there's all sorts of instructions, and there's all sorts of information for you as a provider, contacts, et cetera, et cetera. We also have, particularly in the area of long-term care now, with the Managed Long-Term Care Support Services Waiver, we have Medicaid managed care organizations that participate. For the most part, if in some way you're an organization that is going into managed care, you will have to learn a whole series of requirements that are particular to the managed care contract that the state of New Jersey has. That is also online, and that is also about 700 pages long. For the most part, other than one or two long-term care providers that are on, I believe, on the call, I don't think anyone on the call right now is going to be dealing with the Medicaid managed care organization, so what I'm going to discuss is primarily dealing with the fiscal agent, Molina, and the regulations as they're applied. But keep in mind that regardless, even the managed care organizations have standards which you have to comply with, which you must meet in order to be to file an appropriate claim and get paid. So, what's the difference between what you may do now as a provider with a deficit-funded budget plan with the state of New Jersey, where you're getting paid by either the Division of Developmental Disabilities or the Division of Behavioral Services? Medicaid requires much more documentation, much more record keeping. Medicaid requires appropriate certifications and sign-offs on a service-by-service basis. They may require prior authorization. Sometimes they'll require prior authorization by the Medicaid program itself. It may require prior authorization by a physician or a practitioner of a certain level. It's going to require your documentation to support your services rendered for which you are billing. It's going to require that the services are rendered by staff who are qualified to render those services. So what you are doing now, particularly those who are in the deficit-funded budget program and are going to be moving to a Medicaid fee-for-service program, is you are going to find that your staff is going to have to be trained in the specific requirements for the codes and the services that you are going to be billing for. And that documentation is going to have to match up to the bills that were sent in, particularly if you're going to be audited. And Medicaid payment is subject to audit and verification that all documentation requirements are met. Now, there was a pre-webinar question as to whether or not these audits are pre-scheduled or not. How do the audits come about? Well, for fee-for-service type billings, generally you don't have pre-set audits. They're not auditing your budget. They're coming into audit on a sporadic basis to verify the program's expenditures have been appropriately made. So they're generally not prefixed. They can be very, very targeted. The process that is generally used to target fee-for-service audits is based on computer models. They'll print out a high-profile provider, someone who constantly bills the same service. They'll do that to go in and make sure that those services are actually being rendered and that it's not some kind of a scheme just to get payment. It'll be based on your provider profile. It can happen hardly at all. It can happen once in a while, or you can find yourself to be a target. High volume providers are also a great target. They're the ones that Medicaid is most interested in auditing. So, you know, I do think that a lot of the programs that are on the line will have very similar claims for their clientele and could become a target for at least audits upfront to verify that the appropriate services are being performed. Now, this is a little small to read, and I apologize for that. But in submitting claims, each provider service manual has information which is relevant to the basis of payment for services and items. We went over that. And it's usually found in the second chapter. The fiscal agent supplement is normally included or can be had online. And included in this supplement are information on the proper authorization forms, information for the proper completion and submission of claim forms, the procedure to follow when claims are rejected and returned to the provider by the fiscal agent during the adjudication process. Third-party liability verification. Now, we're not going to talk too much about that, but Medicaid is the payer of last resort. You are required as a Medicaid provider to verify that no third party, that could be an insurer or a negligence defendant, someone who is liable to pay for the care. If you have not done that, you may not get your claim paid and it may get bounced back. There's procedures for submitting crossover claims, which could be Medicare or Medicaid. Has information on the electronic media claim submission, remittance advice statements, electronic funds transfer. Molina doesn't usually pay by check, you know, and I don't think anybody in the provider community takes checks. Adjustments, if there are Medicare adjustments, procedures to follow when a claim is paid in error, which is called a void, procedure for inquiries about claims, procedure for ordering forms, Form 1500s and others, information about provider services and item-by-item instructions. It is important to see what Molina is expecting and to go online and actually make contact with Molina if you can. There's also fiscal agent is not published, so it's not really a law, but it is basically what you have to follow if you're going to get paid. If there is a conflict, and this happens occasionally with all the intermediaries and with all the fiscal agents, they may ask for something which really is not necessary, or they may ask for more than you really need to have in your documentation. Obviously, the law would prevail, whether it's a state regulation or a federal regulation. But for the most part, if you get familiar with the claiming process in Molina, you'll be a long way away along the line of getting paid effectively. Now, timeliness. Medicaid is very strict. Has to be received by the fiscal agent within 1 year of the date of service and 1 year of the earliest date of service if they're on the claim, if the claim carries more than one date of service. Now, for those who are on the call who are not in the program yet or are just beginning to get into the program, I do know that there are billing services available. These claims that you're going to be making, especially in the fee-for-service area, are no different than the claims that are put in by practitioners. Everybody's using the same Form 1500. You will be using different codes. You will need to have different documentation. But the process itself is going to be the same. So You can consider the use of a billing company. I have some that I use or that my clients use, and it just say you're not out only on your own. Now, I like the support program policies and procedure manual. I like it because, as I said before, DDD put in the sort of service responsibilities mixed in with the way Molina processes its claims. So if you read through this manual, 12.1, you'll see that it's presented in a little bit different way than the Medicaid manuals are presented themselves, yet it is relevant to every provider because it really steps through what you have to do to process your claim. So you have to follow your standards, qualifications, etc. That we all know. You have to develop strategies with the individual receiving services to assist the individual in reaching his or her outcome. That's a DDD requirement. That's not a Medicaid requirement. That's DDD. So it's intermixed. Then you have to complete and maintain documentation as required by Medicaid. You have to make your claim for services according to Medicaid's standards, the Molina standards we just went over. You do have to provide the service and supports, though, within the individual service plan, which is a DDD requirement. The same thing with becoming familiar with the individual's vision, outcomes, etc. That stuff which you do anyhow. You have to participate in the planning team. That's DDD. The next requirement, though, is complete and submit reporting documents as required, which would be Medicaid. Comply with monitoring, auditing, etc., conducted by DDD, which would be programmatically, or by Medicaid Molina, which would be on the payment. And comply with all the procedures and standards that you're required to comply with. It's a very interesting presentation. I don't know whether it's legal or not for DDD to do this, but I think it's a nice way for them to have put it together. This is also from the new Supports Program Policies and Procedures Manual online for DDD, but it's applicable to really all providers, which is on the claim submission, which we talked about. Must be done within a year. Medicaid is very strict, simple statements. They've summarized it very nicely on 12.3. The delivery of service must be properly documented, along with any deliverable documents necessary to substantiate the claim in case of an audit. And the auditors will look behind your claim. They always will ask for the documentation. Services may have specific deliverable documents, and these can involve the reports, the timesheets, when you met with the person, how long the session was, what was done, was it a covered habilitation service or not, etc. Each one of those has to be met. That is, your staff has to maintain that. They have to fill it out, maintain it. Service that needs prior authorizations, there has to be proof of it. Claim must include participant information so it can be tracked to the Medicaid identified beneficiary and can be found within the code that you're working off of. Again, you see there is the number for Molina, 800-776-6334, or the website, again, the NJMMIS. You have to become familiar with that. You have to then, whoever is the contact, whoever is the billing person, the billing office, or the billing company has to be familiar with what Molina is expecting on those claims, and that has to get transmitted back to your staff. Why? Because your staff are the ones that are responsible for documentation, right? And these are a few of the issues that are purely documentation issues that I've come across over and over and over with Medicaid auditors, Medicare auditors, regardless of the type of provider. Failure to complete the requirements of the manual for services. You have to take 8 steps to bill for the service, and you only do 6. The auditor is going to come in and say, you didn't do all 8, we want the money back. You may get the claim paid because you may not have to put in a documentation, but on audit, you will face a recovery action. Cookie cutter entries and lack of individual assessment. That is something that comes up routinely as a problem. because it does not document that the resident patient individual was actually seen, actually assessed for whatever service. Failure to document medical necessity is a big issue. If you don't have medical necessity, you're in trouble. Failure to have supporting documentation in the medical record. Okay, the documentation should be in there. You can't say my staff would have put it in there. I think documentation by exception is difficult to prove when you're dealing with an auditor. I think you have to have your actual affirmative documentation in there. Failure to sign and date. Same problem. Yes, you have the documentation in, but you didn't put it in there. You didn't sign it. You have illegible entries. I had the DOJ, Department of Justice, tell me last week that they wanted to deny claims in an investigation because they could not read the attending physician's notes. So that's a real problem. Timeliness of entries, prior authorization we talked about, and there is a lack of communication between the clinicians and the billing company or the billing people in your program.
So Ivan, you've spoken a great deal about the risk providers can expect through documentation. It's my understanding that there are some additional risks that have been increased recently. Can you address those to the audience?
Right. So I think it's important for the audience to understand that we have a series of agencies that have jurisdiction over you as a Medicaid provider. And as we go, starting at the top and go down to the bottom, the people at the top are most concerned with the services that you have performed for a beneficiary. Okay, that's mental health, developmental disability, Division of Children, Department of Children and Families, Department of Health. They are most concerned about the quality of care, etc. As we go down the line, the agencies become less concerned about that and much more concerned about the money. So Medicaid is concerned about the payments, DMAHS. CMS is concerned about the payments that Medicaid is making to you, that they've been appropriated. So they will audit you or they may audit Medicaid. The Office of the Inspector General audits CMS and Medicaid and may audit you. The Medicaid Fraud Division in New Jersey of the Office of the State Comptroller, Department of Treasury, is only interested in money. They really are not interested in the quality of service you provided. You cannot go in there and say, I'm a great provider, but I'm sloppy on record keeping. They are unforgiving. They only want the money back. The Medicaid Fraud Unit is exactly what the name implies. It is only concerned about criminality, about prosecuting you. And the U.S. Attorney can audit everyone above that, in that list above them, and pursue a provider regardless of what those other agencies can do. And they can pursue on civil and criminal activities. So what else do you have to do now that you're at risk for? Well, this is again from the supports manual. You have to do mandated background and exclusion checks. You have to check the federal database. You have to check the Office of the Inspector General list of excluded individuals. You have to check states, the state system as well. There have been questions that it's very difficult. People have the same names. This is an unforgiving requirement. You have to verify that your employees are not excluded on one of the websites. If they are, you will be asked to pay back the money, any money that they were involved with generating for you, whether on a claims basis or if it's a per diem basis. Believe me, Medicaid fraud and the federal government will ask for the money back. Your risk now for auditing, again, nicely put by DDD for you to understand that there's going to be an ongoing evaluation of service providers to ensure compliance with the DDD standards. That would be your quality of care and Medicaid claiming, routine audits, other methods. That may include on-site visits, interviews with staff or contractors, questionnaires, licensing and certification inspections, which you're familiar with, reviews of policies and procedures, trend analysis, other methods deemed appropriate. All service providers will be subject to both fiscal and programmatic reviews and audits on a regular basis by Medicaid and the division. I think that's a big change for those of you who are DDD providers. I think it's going to require you to make a big change in the way your staff documents, the way they're attentive to the needs of the individuals and the needs of the organization to be able to claim. So where do we get overpayments? We get overpayments that cause recoveries, sometimes cause criminal investigations, when the overpayments are duplicate payments for the same services. Payment for non-covered, non-medically necessary services. The services were not actually rendered. They were not, you don't have documentation. If you don't have documentation, it wasn't rendered. That's what it means. Payment should have been made by a primary insurer and was not. No order for service, incorrect coding, that's a familiar one. Excluded ordering or servicing person, that's where someone is on the list, they got through your checks, and there are companies that will do the checks for you. They are services you can hire that will check every month, will check the list for your staff. Okay, so you may consider hiring someone to do that. Service by an unenrolled provider, that could be you could have a psychologist who's not enrolled in Medicaid do the service, but it's billed by someone else, a psychologist who is enrolled in Medicaid, and that's a no-no. You just had service by an unenrolled provider. Service by a person lacking the required license or certification. If you're required to be a psychologist, you can't use a social worker. If you have to be a clinical social worker, you have to use a clinical social worker, not a regular social worker. You have to have the right level. You have to know what level is required in the manual, and then you have to provide it. Service which is inconsistent with the physician or a treatment plan, and services not documented by regulation, which we've talked about.
Ivan, just as a follow-up to that, some statistics regarding the frequency of claims. These are provided by the carrier who offers the coverage that we'll talk about briefly at the end of your presentation. But just to give some sense to the audience as to the magnitude of the claims, payment for non-covered, non-medically necessary services, they see 40% of their claim defense in that area. Incorrect coding is approximately 35% of the frequency of claims. Duplicate payments of the same services come in around 17%, and service not documented as required by regulation, about 8%.
So that would be across the board, all types of providers, and no one is really better at it than any other type of provider, at least based in my experience, except that the larger providers like hospitals and significant nursing homes or things like that who have electronic health records can sometimes avoid some of the issues that Rich and I just went over on this slide. Other risks you're going to have is that with Medicaid, unlike your deficit-funded budget, you're not going to get a check at the beginning of the month to cover the next 30 days. Once you're on fee-for-service billing, you're in a regular cash flow like any other business, and your payments can be withheld if there's reliable evidence of fraud or willful misrepresentation, and that can be devastating to a company, a provider. It can go for a period of 6 months where you can have your Medicaid money withheld. So that is a significant risk to every provider. In addition, providers can be excluded based upon a wide variety of reasons that are listed in the Medicaid Administrative Manual, using suspension, debarment, disqualification. Each one goes for a separate period of time. So these are very, very devastating actions that can be taken by the government but are rarely taken by the government and generally would require some malfeasance or gross negligence or criminality. Overpayments is a different issue, though. As I said before, Medicaid fraud, OIG, everybody wants their money back. Federal law provides that overpayments that you have received must be reported and returned within 60 days of the later of the identification of the overpayment or the date any corresponding cost report is due. You do have to make the overpayment to be reported to either Medicaid, CMS, Molina, or the MCO if you're working under a managed care contract with a written explanation of the reason for the overpayment. There are penalties if you don't do that. Under federal law, the retention of the overpayment becomes, beyond the 60 days, becomes an obligation under the False Claims Act, and if you don't do it, you could be subject to fines for civil monetary penalties. You could even be subject to criminal prosecution. So the overpayment issue is a significant issue. In New Jersey, they have the Office of the State Controller has a informal, it is not by law or regulation, but a self-disclosure protocol to include the reporting, explanation, and return of overpayments within the 60 days. As per the Medicaid Fraud Division, the benefits to you is if you do it, you self-disclose, you avoid false claims penalties, there may be a forgiveness or reduction in interest payments for up to 2 years, you can get extended repayment terms, waiver of penalties and sanctions, timely resolution, and decrease in the likelihood of the imposition of a corporate integrity program. And that works. I have taken providers through that system, and I can say that system works. It also works on the federal side for Medicare providers. So the last item that I mentioned was a corporate integrity program. That is what the government thinks is the single best and most effective way to provide for a limit on overpayments, false claims, and to make sure each provider is operating appropriately. We don't require Medicaid providers in New Jersey to have a corporate compliance program. It is encouraged if you get more than $100,000 a year in Medicaid. There is uniform requirements, the 7 steps of a corporate compliance program. These 7 steps came originally from the Security and Exchange Commission in the time frame of the Enron and other Adelphia, all the fraud that was going on as part of the overall sentencing guidelines that were used for corporate fraud. The 7 steps are universal, whether you're IBM or you're an individual small provider. These are universal steps that have to be followed. You have 7 fundamental requirements. You have to have written policies and procedures. You have to have someone designated as your corporate compliance officer, someone who can go directly to the governing body, whether it be a board of directors or whoever, owners. You don't obviously give it to someone who's got a history of criminality or violations. There has to be an effective training program. There has to be an effective communication program. There has to be internal monitoring. There has to be enforcement of standards and disciplinary policies for people who fail to report suspected problems or engage in non-compliant behavior. And there has to be prompt response corrective action. You have often heard, I'm sure, that there might be things like you have to have a hotline and stuff like that. And again, for those of you who are just going into Medicaid, there are outside services that provide such things as hotlines, etc., for you. So that's my summary of the risks of going into Medicaid that a provider might experience. Part of the reason we're having this webinar today is to discuss what options might be available to you. Rich has got a couple of answers for you on that and some background information. So, Rich, I'm going to turn it over to you for a few minutes.
Thank you, Ivan. I appreciate the information you shared with the audience. I'd like to add some additional information to what Ivan's been talking about. As he's discussed, an audit can be expensive from the potential fines to legal costs. And one of the concerns many of my provider clients have raised is to whether or not there are insurance coverage available to cover these costs. Our clients include social service agencies that will be billing high amounts to Medicare and Medicaid. We found nonprofit organizations like long-term care facilities, rehabilitation facilities, mental health organizations, and other social service agencies are increasingly targets for audits, specifically in New Jersey because it is a new program, and we'll talk a little bit about some of the audit facts associated with what will bring on an audit, and Ivan's addressed it also. So we see this as a growing threat or risk management issue for our clients. While most agencies carry professional liability insurance and directors and officers liability coverage, these policies don't typically cover regulatory audits or don't provide enough coverage for these actions, and in particular for fines and legal fees. One way to protect your agency is to have an insurance coverage that's specific to this. We've been recommending a program called Med Defense. Before we talk about the program specifically, what I'd like to talk about is just some facts regarding an audit. The government typically does not do the audit. They hire contractors, which are called recovery audit contractors, and these auditors typically are not medical professionals. What's particularly troublesome with these auditors is they are paid on a contingency fee basis between 9 and 12%. And also whistleblower claims can be as high as 25%. So this would be an individual working in an organization who suspects incorrect billing or fraudulent billing, brings it to the attention of the state and federal government, and they're incented to do so because they'll get paid a hefty contingency fee. The appeals process can be expected to take up to 12 to 24 months. It is a very rigorous and detailed appeal process. If you miss dates that are predetermined within the audit process, you lose your right to appeal. The carrier has provided me with some information regarding the success of their product on appeals. These are 2013 carrier statistics, whereby their success ratio was 80% of appealed audits versus individual appeals by individual practitioners of 56%, and even the Hospital Association at 77%. What's important to know about the coverage is it applies to both actual and, more importantly, alleged billing errors. The policy will provide coverage for shadow audits, which are audits that they will pay for to basically counter the allegations being made by the RAC auditor. These audit costs can range from $500 to $550 an hour. Average legal costs for even some minor infractions in this billing process can reach as much as $100,000, and fines and penalties can reach as much as $500,000. So the coverage has eligibility to the various organizations that are shown here on this page, and you can see that the broadest of the categories is billing entities. If you are billing Medicaid and Medicare, you are suspect, or you are subject, I should say, to these type of audits. And what we anticipate over the next several years, because this is a relatively new program being adopted by the population of DDD providers, is that over time these audits will start to increase, will be targeted in the state. Limits are available up to $10 million for each claim, and that would be if you buy a product that is associated with the defense product. It's called E-Med coverage, and that is a cyber liability policy. The coverage can be purchased to include just the Med Defense for the audits, fines, and penalties, or you can purchase at a reduced cost coverage for cyber liability as well. And just to go over some special features of the program, again, it provides defense costs and civil fines and penalties for billing errors, HIPAA, EMTALA, and START proceedings. You can buy standalone HIPAA protective coverage, defense costs for fines and penalties against HIPAA proceedings. What's important to new entities entering this billing situation is it does provide full prior acts. So it's in New Jersey, it should be interesting because the carrier will have a better opportunity for new entities that are billing Medicaid and Medicare to have a time reference, but you can buy full prior acts. What that means is there is no date that would exclude billing errors prior to the inception of the policy. A broad definition of insured includes contractors that you might hire to help with the billing. Broad definition of billing errors and proceedings. What this means is they're going to cover both governmental, but mostly these are commercial payer audits, which are the RAC audits and investigations, again, the whistleblower claims. And under the policy, you can self-disclose. If you feel that if you come across issues internally, realizing that you've had some of these errors that Ivan has expressed earlier, you can go to the federal government and the state government and you can say to them, we've self-audited ourselves and we understand that we have some issues here and we'd like to address them. The policy will actually provide you with help in that area. An important property of the program is also that you have choice of counsel under the policy, so that while they provide panel counsel, you can also choose to use a law firm that is an expert in this area if you feel that they're beneficial to you and may not be panel counsel. Medical board proceedings are reimbursed. Defense coverage is reimbursed. And again, I mentioned earlier that the payment for shadow audits is covered under the policy. So
I'd like to just mention, since Rich did mention a couple of things that we haven't gone over, which are significant, in particular when he was talking about the whistleblowers, the key TAM, who are entitled to anywhere between 15 and 25% of a recovery. Make it clear to everyone that in an organization, when you're a Medicare and a Medicaid provider, everyone could be a whistleblower. So we have had occasions where the CFO has been the whistleblower, the CEO has been the whistleblower. In all reality, the only one who cannot be the whistleblower is your attorney, if they're acting actually as your attorney, not just an attorney on the board. So one word of caution is that as you go through your compliance plan, as you will at some point in time, and your compliance program, you have a statement, at least annually, from your employees that they have neither witnessed nor committed any acts in violation of Medicaid or Medicare. No fraud, no overpayments, they're not aware of anything. And I also recommend, just as a matter of course, when someone leaves your organization on your exit, you get a statement to the same effect. And then finally on the HIPAA, which we haven't talked about because for those who are not familiar, the Health Information Protection Act pertaining to health information, electronic and otherwise now, has its own set of rules and penalties, and there are proceedings you must follow if there's a breach. Now, we're not going to go over any of those things because they're state-specific and federal. New Jersey has its own specific. So these are important items. A single HIPAA violation, a breach, just the investigation alone, and this is, we're speaking from experience here with my clients, an investigation alone and if we have to do a disclosure on a single breach can sometimes run $50,000 to $100,000 in legal fees by the time we get done with it. It simply requires a whole host of information to be obtained, to be dealt with, and there's a strict protocol to be followed. So in my mind, Having done this for 30, going off, actually this is my 40th year as an attorney and 30th year doing this stuff, even more. I do think that folks have to be proactive and reach out everywhere they can for protection, including a program like this perhaps, and some of the other things I suggested, help from billing companies, help from compliance companies, etc. We did have one or two questions.
Well, I just I just wanted to circle back very quickly on the med defense, and I think Ivan's comments are important to take into consideration. I mentioned that most agencies carry various types of coverages which may or may not provide this coverage. One of the key benefits of these programs and any insurance program is the provision of legal defense and counsel. So in a situation where there may be coverage, say under your directors and officers liability coverage, typically I would think that the provider of legal defense under those policies is probably not as well versed in these types of claims, and unless their practice has a specific practice associated with defending these types of audits, the benefit of an insurance policy with panel counsel that would be able to provide that, or an organization like Ivan's who has provided this type of defense to its clients, is key to your success in surviving the audit. So if you are not sure how properly insured you are for the Medicaid audit process, please feel free to reach out to us. We would be more than happy to give you some additional advice in this area. I don't believe we have any specific questions. Excuse me, we do have one specific question on today's content.
Yeah, we got one question in that we didn't answer, which was how do the Medicaid eligibility rules get amended? And they get amended by statute or regulation only. So if you think that the Medicaid eligibility rules should be amended, you should go, one, talk to Medicaid for a regulatory change or the commissioner's office, and two, go to your local state legislator and make your case, because that is, the eligibility is a law, and it would then have to be approved by a change in eligibility would have to be approved through the state plan by CMS. So to the extent there's that issue, that would be the question. The second question was an example of the statements to have employees sign, and generally it's a pretty direct statement, a certification that I hereby certify that I have not seen any illegal or inappropriate activity during the past 12 months or during my employment with the whoever the provider is. We at least want it on paper that we have made the inquiry, which helps with our compliance plan fulfillment, and two, that if there is a claim later by that person, and they say, well, there's this ongoing problem that's an overpayment or criminality problem, you have some documentation that you had asked that person, and they had certified to you that there was no problem. You may not get people to sign it; they'll only do it, it's a voluntary request. But that would be the basic statement that you would get. So I think that was the last question we had. Oh, there was one question that came in before regarding a non-approved provider that is a little very specific that we'll address or I'll address separately because I don't think it really applies to everybody. But I think that's it for our questions.
Yeah, I think so. We're butting up against the end of our webinar time frame here. We appreciate your participating in our webinar. I'd like to thank Ivan for his presentation today.
My pleasure.
Once you exhibit the webinar, you'll be asked to complete a short survey to provide us with your valuable feedback. We will be sending some additional follow-up information shortly that will include a recording of today's session, along with a copy of the slide deck and our full contact information. Thank you again. We hope that you will join us for future webinars in the future, and we appreciate your attention to our presentation today. Have a great day.